Vous accueillir aujourd'hui au Policy Center for the New South. J'aimerais tout d'abord vous souhaiter une très chaleureuse bienvenue au nom de notre président, M. Karim Lainaoui, et souhaiter beaucoup de succès à ce panel très intéressant qui portera sur la nouvelle politique européenne de voisinage post-COVID-19, qui est l'appui de l'Union européenne au Maroc dans la généralisation de la couverture maladie. Cet événement
of medical coverage. So this event is taking place in a context post-COVID-19 context, which was marked at the planetary level and has revealed and shed light on the many vulnerabilities. This has also allowed us to become aware of the necessity to take charge of the social sector. The healthcare is obviously a priority and a vital interest, particularly why this is the reason why this great topic is something we'll be focusing on today. So I'd like to briefly recall that Morocco has made great achievements over the past 2 decades through at least 2 milestones. So the compulsory medical insurance, AMO, and the RAMED. And given that these projects were extremely important, however, they were limited because they were targeting limited segment of the population, whereas this included the active employees and their families. However, this did have a limited scope, but it was still had some interesting prospects, and the King Mohammed VI launched a major structural project for social security and social protection, and which also included the mainstreaming of compulsory medical insurance at the as a top priority for the year 2021 and 2022. Obviously, healthcare is a fundamental right, and mainstreaming healthcare has a cost. This is an investment whose gains will obviously be invaluable. So today, the challenge is, first of all, to be able to succeed in achieving this project and also face the different challenges that this project entails. So first of all, the different components, because there are heterogeneous components, but also to ensure its sustainability, its accessibility to the basket of care. And so there are many questions. So there's the legal framework, and just to name a few of the issues that this panel will have the great pleasure to discuss. But I also, before giving the floor to our guests, I would like to underscore the importance of this major project, which ambitions to overcome these challenges, but also to harmonize the system on the legal framework, from a legal standpoint, from a governance standpoint, as well as the different stakeholders. And so overall, the goal is to have a sort of universality of the system, which includes equality for all with respect to access to the basket of care. And so providing these services to the population is an objective that must be met. The European Union is a long-standing partner, which is continuing to support Morocco. In fact, it supported the AMO project from a technical standpoint, and the financing is endogenous. It is essentially based on the contributions of the members, but also the state budget, employers, etc. So Moroccan institutions, namely CNOPS, CNSS, ANAM, the Ministry of Health, the Ministry of Finance, have developed know-how and expertise in this field. The Policy Center for New South. At the Policy Center for New South, our ambition through this event is to densify this dialogue with an analytical density through our experts, but also to associate our researchers at the Mohammed VI Polytechnic University to ensure that this is a project that is endorsed by all. We'd like to wish a warm welcome to Madam Ambassador, and through you, we'd like to benefit from your experience, your European experience in particular, especially to tell us what we shouldn't do. And we also would like, beyond this meeting, we'd like to be involved in the entire process. So this is a process that must be developed. And so we're here to be involved and even to provide support to the executive institutions with the main goal of succeeding in achieving this great project and successfully implementing it with the target populations. So to discuss this topic, I have the great pleasure of giving the floor to Madam Ambassador to the European Union, Claudia Ude, who is our keynote speaker. And so you are invited to hereby take the floor. Thank you very much. First of all, I'd like to warmly thank you for this great opportunity and for giving me this possibility to be here with all of you and to discuss topics which are at the heart of our partnership for a very long time. So it isn't that we have discovered this topic of social protection during COVID and post-COVID. And I'm, in fact, very cautious when by saying post-COVID because I don't think we're there yet, but this is a whole other topic. So, but I'm delighted to be here with all of you today to discuss what we've done in the past, where we're at today, and see what the pathways for the future are. I'd say that this is one of our priorities for the Moroccan and European partnership, which is a very strong and long-standing partnership of reducing and contributing to the reduction of social and territorial inequalities. So this is part of our commitment for a very long time. Europe is often perceived as the historical cradle of social protection, but it is obvious that this has taken quite a few decades to go from these concepts of universal coverage to their actual mainstreaming. This isn't something that took place overnight. There were quite a few steps, challenges and problems and errors that occurred. So I'm not an expert of social protection by any means. I'm surrounded here by people that are far more experienced on these issues, but I can talk from the perspective of a partner of many fields. And in fact, social protection and the mainstreaming of social protection is an objective that is shared between Morocco and the European Union for quite some time. And we shouldn't lose sight of the fact that only 27% of the global population is benefiting from proper social protection. More than 50% of the world's population has no medical coverage. And this is a very sad truth. And so you also, in fact, referred to Morocco's achievements, and this is obviously something that should be kept in mind, that Morocco has already made quite a few efforts and has had some considerable successes in this field, but I think we might all agree that it's still not enough. We still need to focus on what's been done and to continue making efforts for the future. And so the message or the declaration of His Majesty the King for the generalization of medical coverage is obviously a very strong declaration, also an obligation for all of us. You mentioned that I'm here to say that maybe see what shouldn't be done and what should be done. I would say that that's not necessarily our approach. Our approach is to say that we are here as partners and we are working on strategies for Morocco. We are not here to give clear-cut strategies to Morocco. And so we are here to try to provide support in implementation and to provide guidance based on our experience and also provide financial support. As you very well mentioned as well, which is also on the title of this event today, is that we have adopted in the beginning of this year, in February 2021, we have adopted a new strategy, which is the new ambitious and innovative agenda for the Mediterranean. So a new agenda for the Mediterranean. So this is a major title, but you might ask, what is the difference between this strategy and the previous ones? And this is the strategy which is a response to the COVID health crisis. And this was a decision that was made before to review certain policies, such as the relaunching the green economy, but also to define a new type of strategy in relationship with countries of the Mediterranean. And I would say that this is the first time that we've had a strategy that is the fruit of a consultative process. So the countries of the region, those that were interested, were involved in several discussions and consultations, and they've sent contributions and they formulated their priorities. And Morocco was a key partner in this process, and that supported the strategy by an annex that set out a list of the 12 flagship projects that concern different areas. And here again, we find Morocco in several flagship projects where Morocco expressed an interest to participate in. And in these, well, among these projects, there's also the social protection and the reduction of inequalities between the rural and urban areas, which is obviously part of our partnership. But here again, there is this is one of the strong points that Morocco formulated. So this list is public, so you're more than welcome to check it on our website. I believe that in Morocco and around the world, the pandemic has shed light on the shortcomings and the failures of the social protection and health care systems. I think this was the case pretty much everywhere. We had to learn lessons very quickly. And what's important is to learn from this experience, which unfortunately is far from being over. So I believe that we've all become a lot more flexible. We've become a lot more responsive. And as such, we need to review things that we thought we understood, and sometimes questioning certain things that there are, for example, cases of people that are vaccinated, people that were already impacted by the virus that got reinfected. So I think that this is an issue that will be very closely monitored and in a very creative and innovative way. So during the first wave of COVID last year, we obviously all leveraged the resources we had.
Avancer, anticiper des ressources pour appuyer tout ce qui était dans le grand chantier sanitaire, surtout on a
support.
We contributed to
the purchase of beds, provide emergency. That was an ad hoc operation service. It was an emergency takeover, and it was an emergency situation that was necessary to be conducted. But here now we are here to decide about the future. We were involved in the social protection sector and health sector for over 15 years. And we have two ways to operate. We have what we call the budgetary support, and we have the complementary aid. The budgetary support goes through the government budget. It is actually an injection of the budget, government budget, based on a government's budget strategy, not our strategy. And we actually discuss the strategy, we exchange experiences, we exchange visions, and we talk about the objectives of the government to achieve the strategy. So we all agree on the progress that could be achieved. in a period of time. So the disbursement of the commitments and engagements we make, follow up, and the strategy implementation. And we have what we call, well, we have a consultation process. We have a 27 member states with a great deal of expertise and experience, a long-standing experience, and we draw their expertise and listen from them according to the needs of government. So it can be anything according to the expertise that is sought and requested. We can launch a consultation with our EU member states with twinning programs, namely, and then we really get that experience from people of, coming and stemming from the administration of member states, but we also have people working in the structures at the EU and also in the governments. So we have the task, the common task, to build this future avenue to really trigger a social protection that could be covering everyone, that could be universal, that could protect everyone. And the government does play a role in here. It has to structure the finance in an appropriate way, because having programs that are financed is a great risk. So we need to have a technical plan with the financing that is matching the needs and the strategy. And I have looked to an analysis dating back to 2017 or 2016, I can't remember very well, of UNICEF, that looked at that in the global sector of social action and social protection, there were over 140 programs that are in the pipeline, so which is huge. This means that there is a great will and eagerness to support, but where the shoe pinches is the consistency, not because of lack of will and financial resources, but the challenge for us is to actually put this in an orchestra that plays together and ensure consistency between different sectors. Of course, not only the health sector that is aimed here, but also access to direct social protection. If someone is ill and is jobless overnight, so how can to ensure that these people do not fall in precarity? How can all these elements and all these sectors play together like an orchestra, so could achieve consistency? So we need to take a big look and a comprehensive look at the package. So I believe that Morocco has made great progress forward with social protection and also social work that has been done is amazing. There's, of course, there is a work ongoing for a unified social registry. This is another key to move into the right direction. So there are different elements here and there that need to be put together in a framework and a harmonized framework according to us. So we also have some ongoing programs that will be finalized over the course of this year. But what would be interesting for you to know is that we are negotiating and preparing a program and intervention that will start hopefully, inshallah, by the end of the year, because we have typically planned to really stay committed in the social sector as a whole to ensure a basic medical coverage for everyone and universal guaranteed medical coverage for all, which for us we consider as being a fundamental right. This is not only a social right, but this is also an economic question for the whole society, because a society who is healthy can be more effective, more productive, can be working more effectively. So this is a shared and common interest, and this is something that is a top priority for us, and we keep giving a close look to it. So we are also discussing with the government so how to actually implement this in the future. in the future programs and strategies. So we are actually designing and drafting a 7-year plan. So we don't have a detailed idea, a detailed elements, but the whole idea is of course about this. And I hope I have touched upon the main paramount problems and elements. So thank you very much, Mrs. Ambassador. So and for sharing with us all these parameters and mechanisms that really make us understand and more understanding about the EU mechanisms on the protection and medical protection and social protection system. So I now want to talk to Mr. Anas Tukali, former Minister of Health, who has honored us with his presence. I give you the floor. Thank you very much, Mrs. Chair. Very dear friends, ladies and gentlemen, allow me, Mrs. Chair, to say a few opening words as planned, and also come back to the discussion panel to recall some very important aspects of our living experience, and also sharing this experience and sharing some ideas on this major ongoing project on the medical coverage and social protection program. So we are in the middle of a pandemic context, and this pandemic is still going on. We're still witnessing the problem, and it has challenged the whole global protection systems and medical coverage systems. It has showed that's the lack of social protection regimes and solid medical protection programs are, of course, an additional challenge of social cohesion. So, of course, adding to this the medical fragility, and of course, in addition to this, the sanitary drawbacks from the economic and health perspective. It has showed us that the ultra-liberal programs and strategies based on economy at the detriment of health and the well-being of hundreds of millions of populations are far from being sustainable or long-standing type of strategies. And the discommitment of the states and the commitment of the states in these sovereign and discommitment of the government from these strategic sectors are also vulnerability for the states. And of course, the social states, so federal states are the ones that have been more solid and resistant and resilient to the pandemic. So a lot of damage was caused because of choices that were made in such and such regions, federal regions. Same for Morocco. The role of the state under the enlightened guidance of His Majesty the King was absolutely primordial and crucial to really preserve health and economy, thanks to proactive management since the very beginning of the beginning of the scourge in China. Several measures that you all know have followed until the vaccination program and campaign that has almost targeted 12.5 million targeted population that have received the first injection, and the last announcement of local production of vaccination with the short-term doses of 5 million per month, so going through economic recovery programs or basic aid and support to preserve the most vulnerable family groups and social groups. But having said that, we can actually see that all these projects launched by His Majesty the King are the most solidary and the most appropriate response to the pandemic, namely the social security coverage. So, of course, we need to associate the economic development to social progress. This is to materialize His Majesty's will, because the social protection is not a burden on the economy or the budget, but it is a prerequisite to achieve a developed economy. Generalization of the compulsory health coverage system at the benefit of 22 million people, additional 22 million people, are one of the major pillars of this outstanding program. Of course, its success is depending on the capacity to pursue the reforms in the health sector and make it sustainable. Of course, to accompany the reforms of the social protection and medical coverage, in particular, it is important to take a series of necessary direct measures and strategies at legislative and regulatory level, on the law, or the law 9815 that is still fresh, on the medical insurance of non-working employees, and the framework law 3409 on the health protection and the care package. And on the financial standpoint, in order to ensure in a sustainable way the solidary contribution of the state, a lot of debates and discussions should be taking place on this sustainability. And the Honorable Ambassador spoke to us about some mistakes that were made in some social protection systems. So we need to learn from these mistakes and gain experience. On the financial aspect, the solidary contribution of the state by really allocating budgetary allocations and the reform of the compensation system will allocate a great budget from the governance standpoint, coordination mechanisms, and a unique instrument of management of the compulsory medical care scheme will contribute to the universal coverage. But there is also a very important lesson to be taken, status of the public service, transformation of the digital, transformation of the governance, and also the implementation of the Charter on Information and Training, job training, and long life training that is linked to the compensation of loss of jobs. So these strategies and campaigns should be conducted in a concomitant way, otherwise it would be a negative impact on the unemployment benefits, which shows that a lot of jobs will be lost because of COVID and other pandemics. So this transformation needs to be accompanied by the training to achieve social and professional inclusion of job seekers, and in order to avoid them living on the paycheck or the providential states. Of course, political reform should be taken in order to bring a new momentum to the new national dynamics and come up and raise some new, modern, and young elite, society, political parties, etc. In other words, many important texts contribute to this renewal of the elites and a more important participation of the population in the public sphere. Generalization of AMO would means the end of the Ramad regime. We hardly speak about it because this is a disruption. It is the end of the regime that lasted for years, that took a lot of years, pilot experience, a lot of discussions, a lot of debates with the help of the EU instruments. This is over for now. And this large project, I have always said it, has never been finalized, the Ramed project, namely, and this is why we can explain some of its limitations, but we need to draw lessons and learn from our mistakes. And the end of Ramed means swinging towards universal coverage, and the whole system will be drawn by the philosophy, the insurance philosophy and mindset. It's good to have some colleagues in the insurance business with us. This is what really happens in the health sector. in our experience, in this AMO experience, through its application and implementation so far, it actually requires an assessment to achieve successfully AMO accompaniment measures on the deep reform of our health sector is more than necessary through the implementation of the upgrading and upscaling up of our care offer in an equal footing and equitable way, human resources and capacity building, valorization of the public sanitary sector with great motivation for the healthcare professionals, dedicating also regional management of the sector, health sector, strengthen it, and make the university hospitals as the locomotives in the regional areas of Morocco. When we were conducting this thinking process in 2018 and 19, we were thinking about the sanitary regions, but we needed a locomotive. Those who receive all the problems of the world in the health sector are the university hospitals. So university hospitals should be involved in the whole thinking process and reflection, and also have a say on the health sector, namely on the health care package in the regions, and also ensure convergence of the public policies in the field of prevention and control of diseases. Health is first and foremost prevention. It's about prevention because we're an average income country. And prevention is not that expensive. It takes tax policies and budget policies. We are actually taxing sugar, some other food products and basic products like salt, etc. So we have new practices in place. Housing, food products. So convergence is really important. I remember well when we first put in place the Charter of Prevention and Control of the non-communicable diseases, accounting for 50% of the morbidity rate in Morocco. We had this charter assigned by everyone and cross-fertilized own harmonized programs should be put in place in Morocco to ensure the well-being and turn the liberal and private sector as a true partner of this reform. 6, ensure the digitalization process of the sector and come up with IT system. Of course, there are other conditions. I just referred to the 6 I just mentioned that are enshrined in the ministerial program, and I'm really delighted about it. So in the framework of implementation of all these reforms, that the Morocco-EU cooperation can play a key role to achieve successfully programs and projects started and implemented by our program. Also, the programs to support social protection in the framework of the neighborhood policy with the EU in the privilege partnership with Morocco is called to adapt to the pandemic context. And this is what Morocco did, the partnership did, and the honorable ambassador just clarified this to us. So adapting to the pandemic context and new strategic decisions on social protection. So the aim of the support program will be fixed and focusing on an integrated and unified social protection system with the financial and operation planning, ensuring its full development, and of course on the extension of the basic medical coverage to all social and professional categories of the population. This is not an easy task because it will require a lot of consultation and improving the coverage for the most vulnerable populations on a long path. It's a fast track actually that will take us to the universal coverage system. Thank you very much. We still have some work ahead of us. Thank you very much, Mr. Anas. Mr. Minister, thank you very much for having inscribed your intervention in this holistic type of approach that really relates the direct interventions to the indirect ones. So the social dialogue will have to go through all these reforms. I am absolutely delighted to host and welcome two prominent and outstanding speakers that will dig and dive into these questions. Mr. Abdelaziz Adnan, Director of CNOPS today. I'm very happy to see again, and we have worked on AMO, on social protection schemes. Mr. Adnan, can you please tell me what are the challenges ahead of us after the royal discourse and debate? You are an architect in this engineering, so we would like to listen from you about hear your assessment and the future prospects in the framework of a Moroccan national work and endeavor, but also in the framework of the partnership with the EU. Thank you very much indeed.
Thank you, Madam Chair. As an actor, it is true that I had supported this reform during the drafting of the law of the implementing text, and I see my friend Mr. Arabi Shaiti, who is also an expert appointed by the late Abdurrahman Yousfi to be part of this commission that drafted the law 6500 and the implementing texts. It should also be recalled that there was a strong political will that supported the development of this notorious law that took 12 years before coming about. And so in fact, the first draft laws that were launched by the late Tayyib Ben Sheikh, who was the former Ministry of Health, and that was dated back to the end of the 1980s. So our country took 12 years to adopt this law 6500. And so for the implementation is also thanks to the involvement of the Prime Minister, Driss Jatou, that this law was in fact able to be implemented since August 18th, 2005 to be exact. So before taking a deep dive into these issues, please allow me to discuss the challenges to which we're faced, that we are already faced with. First, allow me to recall the economic context in which this will take place. And this approach, this does not escape anybody from the state's budget or from the private sector. In this pandemic, and I also like to recall the context of this triple transition, which is demographic, that our country has experienced, particularly the public function. And so this obviously has a direct impact on the sustainability of this insurance system. We are also witnessing an accelerated aging of the population that is insured by CNOPS. So in terms of financing, of the financial sustainability of this regime, this is obviously extremely challenging for CNOPS. There's also the epidemiological transition. There's also the prevalence of chronic illnesses and heavy diseases, because based on our statistics, 6% of the population of the insured consume half of the services. And this is a trend that isn't particularly specific to Morocco. It is practically universal. However, it will tend to worsen over the coming years. So in France, for instance, it's about 12% of the population that consumes 75% of the services, benefits of medical insurance. So there's also the epidemiological transition. And so here, this begs the question of the digital medicine and its different impacts and the innovations in terms of therapies and innovative drugs that are extremely costly. We have some patients that cost us practically 2 to 3 million dirhams per year. And it is through this solidarity that these patients are covered for these to be able to have these therapeutic drugs covered at 100% on a 100% basis. And there's also the prevalence of these heavy and chronic illnesses that continues to grow and exacerbate over the years. I'd like to pause on a certain number of levers regarding this basic medical coverage, which I believe are maybe forgotten or left aside. And these include training in terms of social protection engineering and the management of medical insurance. We haven't been trained to manage these social security funds, so we all learned on the job. And in fact, there may be some information missions, or back when I was at the Ministry of Finance, we had a few opportunities to conduct missions in France or other countries to learn from the mistakes of maybe other countries and see the errors that we needed to avoid. So there is the lack of a training institution, and the players of medical insurance, well, they all manage to make do as they can. And a few weeks ago, I had suggested to the head of government, in fact, I even given him a paper on the future of dossier on a school and a training institution for social security funds. And so this is a project that we had worked on about 12 years ago, and unfortunately has yet to see the light. And by ricochet, all of the necessary studies to be able to shed light on a certain of these points are not commissioned, or maybe are even done in a non-professional way. There are also areas where there are medical deserts, areas where there's no medical care provided. There's also the medical profession as it's exercised today. There's also the quality of medical care, the drugs. We have conducted a few studies on drugs, and I'm wondering why Moroccans have to pay the same drug at three times the price. I mean, the same molecule, the same packaging. So why this price difference? And this is all. There's also. I mean, just to give you an idea, it costs us 300 million dirhams a year, and the same applies to medical devices. So why do Moroccans have to purchase the medical devices for a much higher price than Europeans or even French citizens? Because we tend to make comparisons with France, because the information there is readily available. And maybe these are topics that we can delve into at a later stage. Now, as far as basic medical coverage, I believe that the progress that has been made, well, there have been considerable gains, and as a Moroccan, I am delighted to see the progress that's been made. We've experienced a phase without compulsory medical coverage, and after 2005, we rapidly saw the impact on a great number of insured, including those of the KNOPs who already had a optional medical coverage. In terms of access, they had a much broader basket of care, much shorter payment deadlines, because sometimes before it took 2 to 3 years for the reimbursement of medical expenses. But despite these gains, there are still some shortcomings, there are still some malfunctions that can be summarized in terms of equity, of solidarity, because this morning, in fact, I was at a board of directors meeting with the ANAM, where we have 70% of Moroccans that have basic medical coverage, but we know that these 70% of Moroccans do not benefit from the same type of basic coverage. The insured who has the CNOPS does not have the same coverage as CNSS because the coverage rates for the services are a lot higher for CNOPS than CNSS. But in terms of contribution, the CNSS employee or contributor pays a lot more. For example, RAMED beneficiaries can go to a public hospital and they'll be told, well, you need to buy the medical device, you need to buy the bandages or the drugs, or they will give them very far removed appointments. And so which leads to many patients who end up giving up on their medical care due to a lack of financial or physical access to the medical care. So this is why I think it's necessary to have this refoundation of solidarity. It's important to redefine solidarity. So myself as a Moroccan, I would like for all Moroccans to have access to the same basket of care at the same coverage rate, and even more so for those that have nothing at all, rather than those that have basic medical coverage plus one or two complementary insurance schemes. And it is true that we are all struck by these issues of equity and accessibility for all Moroccan citizens. And we're also struck by the future and the financial sustainability of everything that's being done today. And in fact, in the commissions that we all were part of, Mr. El-Arabi, I always drew attention to the sustainability, the particular financial sustainability of these programs. And the question was whether this basket of care was generous given our financial means, especially given that we started with this basket of care with about 1,000 drugs, and today we have about 4,800 drugs that are reimbursed. And among these drugs, there are some that are extremely costly that we pay for at a much higher price than in France, for example. And which begs the question of financial sustainability, especially when we discuss the extension of medical insurance to the entire population, including those that benefit from the RAMED scheme. And there's in fact a framework that was presented by the Minister of Finance. And so personally, I'm wondering whether this framework will be respected, whether it takes into account a possible revision of the rates, because the healthcare professionals are constantly claiming a revision of these rates. So to which extent can we continue going up until this issue of financial sustainability? And so there's the framework law that was enforced by our country. So to a great extent, it does meet a lot of overcome a certain number of shortcomings. And I believe that the key word for the implementation of this framework law is governance. Because today, governance, as it stands today, basic medical coverage has revealed some serious limitations. And it is important to have some arbitrations, high-level arbitrations. And I'm not talking about the convergence of these schemes. I believe that this is something that's absolutely inevitable to CNOPS and CNSS and other schemes. The Social and Economic Council, there are different institutions that formulated these recommendations. This is contested by no one, but obviously this will have a certain cost in order to harmonize CNOPS and CNSS Well, it is important to readjust the contributions and readjust the coverage rate for the different services, and it is most certainly will have to involve the complementary insurance schemes, because we tend to forget these complementary insurance schemes for mutual insurance companies and others that are offered or provided by insurance companies, which today tend to escape to a framework or a certain articulation with compulsory medical insurance. And this may lead to certain malfunctions or excessive rates. There are some rates which may be considered as national rates, but this isn't necessarily the case. So insurance companies can accept other rates than those that are provided for by the national agreements. This law also had the advantage for the very first time to define the scope of social protection, and this was not the case in the past. The first study that was commissioned on by the social protection system by the World Bank dates back to 2002, and I had in fact participated in it, and we included in social protection absolutely everything, all of the actions conducted by NGOs, any departments that had a sort of social character. And this is why we're talking about 140 programs. And for the first time, this law came about to define the scope of social protection, which truly corresponds more or less to the foundation of social protection as it was defined by the United Nations system. Now, the main challenges, and this is something we discussed earlier, the first challenge is first and foremost the steering and governance of this major project. A year and a half is left before 2022, and obviously the time is of the essence. And I believe it would be necessary to establish a task force to focus on this project and to tackle this project day and night in order to meet the objectives that have been assigned to all of the stakeholders involved, namely CNSS and the relevant ministries. So this is steering. Well, there was an interministerial committee that was chaired by the head of government that was dedicated to the reform of the social protection. And I believe that they will be meeting to accelerate the pace, because I was talking to my friend, the Director General of the CNSS. I said, well, I'm sure that I would be spending more than one sleepless night if I were in his shoes, because time is of the essence. And so end of 2022 is not so far away. So it's very important to make very rapid progress in order to meet all of these objectives. So the second challenge that I wanted to underscore, and here I believe that all of the indicators that we have were clearly reveal this. There is the basic medical coverage, and medical insurance is very poorly integrated in the national healthcare system. And so this scheme was initially devised to serve the national healthcare system in order to address a key issue for the Ministry of Health, which was the financing of medical care. Whereas today, we see that all of the indicators reveal that the financing is a lot more dedicated to oriented towards the private sector rather than the public hospitals. And so these malfunctions and the different challenges that the public hospitals are experiencing will only amplify, and this will be sort of broadened reproduction of the insufficiencies and problems that the public healthcare system is faced with. And without proper financing and substantial financing, The WHO, in fact, has formulated a certain number of recommendations in this regard. And I think that is one of these recommendations is more resources, more financing is needed for the public healthcare system, and more flexibility for the purchase, more flexibility in the purchasing of supplies. I've had more issues dealing with the shortcomings or insufficiencies in medical supplies in medical hospitals and in university hospitals, than anything else. And so there's the financing of the health sector is absolutely fundamental. There's the refoundation of governance, and so this is something that I've already discussed, because as mentioned before, we directors of CNOPS, CNSS, and ANAM, well, we have this possibility of mortgaging the future of medical insurance, because there is absolutely no control on what at any level, neither with the public authorities or the parliament. And so personally, I am advocating for social finances, generally speaking, and the finances of basic medical coverage be truly part of a democratic debate in the parliament. And so it is not a director, regardless of who it may be, who will lead this scheme, this regime to failure. So there needs to be a discussion between the executive and the legislative on all these issues. And this is the major reform that we are expecting from the reform of these laws. So we are all aware of the limitations, because the Bismarckian system, as we've adopted it, well, we can see that the professional contributions alone cannot finance the extension of basic medical coverage. This is why it is necessary to diversify the financing. And I believe that Mr. Anas Ducali has given us a few examples based on the polluting payer principle. For example, agri-food industries, and I would also add the pharmaceutical industry. In other countries, the pharmaceutical industry contributes to the financing of medical insurance. There's also the control of the different services, for example, drugs, medical devices, different explorations and tests. There are many studies that have been commissioned, and this has revealed that there are some situations that are situations of vested interest that are truly detrimental. And this, in fact, was quite astonishing, because we realized between the cost declared at the customs and the public sale price, that sometimes there is a 20, 30, 40 times, the price is inflated by 20, 30, 40 times. And so we wondered whether these importers that generated such high margins. There's also the Court of Auditors, and also there's a Court of Auditors and other institutions that are focusing on this topic. Because it is indeed important to shed light on this matter. There's also prevention. This is indeed extremely important. So unfortunately, as the texts are drafted today, well, they do not involve the intervention of social security funds. It's as if we were simply our role was merely limited to receiving dossiers or medical files and processing them and reimbursing them, whereas there's a lot more that can be done. There's also the articulation of the ammo and the complementary insurance. It's important to also demystify a certain number of figures that are mentioned here and there. And there's also the remaining amounts to be paid. There's also, for example, civil servants today. More than 80% of civil servants not only have a complementary mutual insurance, but they have a second complementary insurance through the 11 foundations that were created. For example, through the education one, the Education Foundation. To provide major services to the insured, to, for example, the population of teachers. There's also the extension of basic medical coverage. Well, it's absolutely insensitive to believe that we will be able to meet these objectives without digitalization. And here again, there's a coordination issue and a coordination and consultation issue, and particularly the steering of this project. So personally, I don't believe that this is a technical or technocratic issue, but rather a highly strategic one. And what's at stake is the digital sovereignty of the country. And the final point, and I will stop there. So my final point is patients' rights. Our country is one of the countries that lacks legislation that protects patients and protects the insurance, because these practices of some health providers that we all know, that you all know, we have all been victims of this. Guaranteed checks or refusal of providing care. I think it is high time for our parliament to promulgate the law for the protection of patients, and also to patients also need to have a word in the boardrooms of these social security funds. Thank you for shedding light on all of these challenges and shortcomings and gains as well. And so obviously the goal here is to achieve the objectives set for 2022. And without further ado, I give the floor to Mr. Arabi Jaiti, another expert who has also was also one of the architects of the AMO, the compulsory medical insurance. We worked together in the government of the late Abdelrahman Yousfi, and you were one of the advisors, Mr. Arabi Jaiti, Senior Fellow at the Policy Center. You have the floor.
Merci, Madame la Présidente.
Thank you, Mrs. Chair. So what can I say after these outstanding words and presentations of my distinguished colleagues and the Honorable Ambassador next to me here, and I'm so happy to find friends again, see them again with Mr. Adnan Nemeli. We have made quite a long journey together across a lifetime together, and we've worked on the life insurance, and we've been there in the battlefields together. And me as an analyst with this short participation and drafting of this new first pillar of the basic insurance, this medical insurance. And I would like to also thank Mr. Ducali to have kindly replied to our invitation as a policy center. And I have shared with him the common concern, the public concerns, and the collective needs and interests. And also with the Honorable Ambassador and Distinguished Ambassador, we have had the honor to meet her again and discuss the Euro-Mediterranean relationships. This is a theme that I've been working on tirelessly for years, and now we are on this journey and path of the Euro-Mediterranean cooperation and Moroccan EU relationship that is at the best interest of our people and nations. Much has been said that I fully share, and I would like, and I even say that I share with words and mind, and I would not dwell a lot on what was said before, but just to bring a different perspective and different look, and maybe highlight some of the questions that really keep me thinking since the relaunch of the medical insurance and the extension and enlargement of the medical insurance. Of course, there are some concerns and challenges towards this universality. We have made major steps forward that were reminded from AMO, which is the medical compulsory insurance, and some other interesting initiatives, namely despite its implementation difficulties, and also some other reflections on the extension of the medical coverage for non-wage owners. Also, some very interesting projects carried out by the CNSS on the extension of the social security and medical coverage to farmers, to fishermen, to artisans. So this issue of universality dates back for years. It's not brand new. It was in the mindset and the philosophy of AMO and in other initiatives that were taken. And we've seen the time go by, some good initiatives, good eagerness and willingness that were expressed by stakeholders, by the government and the public sector, and some stakeholders of the social prevention, and the hard time they have in implementing this program. So, and now there's the urgency to go faster. It was actually expressed at the highest level of the states, but it seems to us that the 2 years ahead of us are going to be extremely difficult to meet that challenge and to get there. And why is it going to be hard to get there? Because the universality started some years ago, or the universality process started some years ago, and is facing now the enlargement to a very heterogeneous population. We're not in a wage earner world. It was already so complicated to come up with a system within with a population having the same social status, regardless of the differences between public and private sectors, but would make things easier to manage. Today, we have come to universality and achieve universality by touching and targeting some private sectors and liberal professions and artisans, farmers, fishermen, all those professions and segments that were actually referred to in the generalization text with a very objective to go faster. And of course, there are initiatives taken here and there that show that we are on the right track, and conventions that were signed with some professional organizations that are very important. But this is only a baby step we're making to go and face the difficulties and challenges. And one of the most important challenges is the contribution aspect that we were faced with this year. Of course, as I was saying, heterogeneous population with contribution base that is quite and professional possibilities and fees that are different according to the professions. Lawyers are not fishermen and farmers, etc. So this heterogeneity is so delicate, but this can only be done gradually in progressivity and in a framework that is based on partnership and discussion, because this is all about involving the beneficiaries, but also the representatives of these beneficiaries. It is a matter of representing the beneficiaries. This is not an easy task to take care of in the negotiation process between the public ministry and public authorities, stakeholders, and professional organizations. So this is, to my mind, one of the most important problems heterogeneity and the complexity behind it, and lying all this behind it. So, and the other second challenge that was referred to by Mr. Anas and Mr. Adnan is not only about the enlargement, but also correcting the dysfunctioning of the existing system in the same momentum and the same dynamics and approach, and corrected the dysfunctioning of the existing system is about the harmonization of the system. So harmonization of the mechanisms on which it is built and constructed to make sure that equity and solidarity are fully respected. These are the two main and fundamental principles on which AMO is based and constructed on. So we're trying to achieve cohesion of the system, and this entails huge, complex problems. The first one is what we call the healthcare package and level of coverage, the control of the registration or double registration. If you see the RAMED configuration moving from this existing system to the universal system, that is also problematic. And also the rate of coverage of this healthcare package. Not only we need to agree on the healthcare package and medical offers, but also to figure out the coverage rate that needs to be attractive and effective, and also needs to be dynamic enough to be negotiated to take into account this fundamental question of equilibrium and balance between financial resources, constraints, and at the same time the healthcare services that need to be provided. So this is a delicate question, a very touchy question that needs and requires very steady monitoring. So we spoke about the healthcare package, pharmaceutical product, that is so important in terms of turnover and revenue, but also the, if you look at the epidemiological evolution of the country, and the most important thing to take into account is the heavy management of the very, very serious diseases. So this issue of consistency is absolutely paramount and really entails healthcare package, coverage level, harmonization that can only be achieved through an efficient governance approach, and demanding in terms of accountability and responsibility of all the stakeholders, of course, social security organizations, but also all other stakeholders and players like the medical professionals, and also the responsibility of the patients at the end of the day. So this harmonization of the system is not only faced with the issue of heterogeneity and the correcting and amending the existing AMO, but also the solutions that we will come up with after the reform of RAMED. But let's face it, it was a huge ambition, and it still is, because it actually covers and targets the most vulnerable social groups, the informal sector, people, and the rural areas and remote areas. But the RAMED, as we know, as we see, it was already in a very delicate situation for the issue of targeting financial resources, management, the financial resources that were allocated to this regime, and also the issue of governance between all stakeholders. So reversing and reverting the RAMED and moving into a universal system, this entails to come up with a unified and universal system and mechanism that will be the umbrella under which all these programs will operate. So regardless of the issues of consistency, harmonization, reverting and shifting the classical AMO to a universal system, so the parameters that are based on are very well known by everyone, but we need to address them, every one of them, with a lot of rigor to ensure the sustainability of the system. And the sustainability of the system is, of course, about its financing. Financing is crucial. Of course, it needs to be balanced, but we need at the same time to have a sustainable financial resource. And the other important thing is these financial resources will ensure its accountability, but also will provide legitimacy to the system, and of course, it has to be based on equity from the contribution side, from the fees side. How can we manage this? If you look at this disparity of the beneficiaries and beyond the efficacy or rather equity, it's or fairness rather, it's the issue of the employment and efficacy and employment of the resources and efficiency of the universal system. So these are the three main principles that need to be taken on board in the framework of a mechanism that will ensure the fairness of the fees and ensure the global performance of the system. And in the rationale of the financing and the role that can play the state at the same time in the management of the RAMED beneficiaries is the control of the expenses and expenditures, because we're thinking a lot when we talk about enlargement about access to healthcare services, healthcare package, and healthcare services in general way, but we pay a very little attention to the control of the expenses mechanism. And one of the most important mechanisms in terms of prevention and accountability is the prevention. And prevention is one of the main challenges for now, because we have these three levels, the first tier, second, and third tier, because today prevention is more important than ever, because when we've seen that epidemiology shows that we're heading towards heavy diseases. So we need to come up with anticipation. And anticipation takes time, takes costs and expenditures. So we need to strike a balance between expenditures and costs, and hopefully we will move towards a much more operational management of our resources and achieve sustainability. The second chapter or part of the expenditures control has been spoken about, but very well taken care of, is the whole, what we call the healthcare journey, or actually that will involve the medical doctor, but also the specialists and the family doctor. So how to actually manage the relationship between the patient and the healthcare services and package. We know that the dysfunctioning of the healthcare services have been there for years in Morocco, and all of a sudden, we have a freedom of the patients that will have to choose what products he wants to have. So we need to rationalize the behavior by the patient and rationalize also the behavior of the patients by the incentives and rationalization of the healthcare products that should be coherent and consistent. And this healthcare journey needs to be one of the vector of contribution and control of expenditures. And another question that was mentioned is the issue of financing and expenditure management is the weight of the medication and drugs. 33%, if I'm not mistaken, of the global expenditures of the healthcare is allocated to the medications and the drugs. One third. So it's huge. This is huge. It's extremely heavy if you compare and benchmark with international standards. I think even if for the most developed countries in Europe, it's roughly about 15-20%. So this weight of the medical expenditure should be amended or modified through a meta approach with what we call a drug management policy. I'm not to dwell a lot on this, but this really weighs a lot on the insurance, medical insurance and disease insurance, etc. Another way to control those expenditures is through conventions or agreements. This is a daily business and a regular issue in the medical practice, and it really poses fundamental questions on the pricing, but also on the virtuous behavior of the medical personnel of the private sector, prescription control. So all these aspects are extremely important. So I think there is a long debate going on. It's been going on for years, this issue on conventions relating to pricing, IT systems and control systems, namely in the liberal medicine. And sometimes you see that there is a deviation towards exaggerated costs and expenditures. All this is related or linked to a central issue is the information of the systems. So information upwards and downwards on targeting, on follow-up and monitoring of expenditures and conventions. And of course, the digital today is one of the key tools that will help us achieve more productivity, rapidity, and accountability for the finance part, but also the conventions that are signed and MOUs between stakeholders, healthcare institutions, and all other stakeholders. So all these is discussed in the framework of this debate on governance. And the governance requires from us to really amend and upscale some laws to adapt it to the new context and new momentum. And we should ask a question. So are we going to this unified system? What about the ANAM in this new momentum and mechanism? What about the prevention, social prevention organizations, and how to involve everyone in the enlargement process and the coverage of the insurance, medical insurance in general? And what are the instruments and mechanisms that will help us achieve transparency, governance, so very clear standards on which governance should be built? So from these parameters onwards, I think there are some fundamental questions to be asked. That, for me, are not that present in the public sector is the redefinition of the relationship between the medical professionals, the public powers, and the medical insurance institutions. How to come out from this segmented organization of the health sector, much more coherent and consistent, and how to mitigate the inequalities of medical services between the regions, because we are now moving towards decentralization, deconcentration, and generalization. So we need to think about a national project, but also with an implementation at local, regional level. So we need to achieve much more autonomy and monitoring that should be given to the players locally and regionally. And what is the role of patients? And what is, in terms of rights and responsibilities? We agree on these two things and fundamental elements, because sometimes disinformation can lead to some non-virtuous behaviors and attitudes, both from the patients and other stakeholders, that could result in deviations. And what quality of the healthcare services? We talk about access to healthcare services, but the issue of quality of healthcare services is paramount, and the quality of the public services is another hot potato and a very important thing in the overall healthcare package. And of course, lastly, how this whole mechanism is decided upon, and what are the decision-making processes in this
dans la scène
mechanism
publique.
and for the sake of governance. So these are the main questions that are to be asked in the public sphere and era, and we should show, of course, ambition, willingness, and eager, but we really need to understand the weight of the constraints on these projects, weighing on this project,
Forme d'annonce
not to be dragged in a kind of announcement that might have a negative impact on the population at large and the public opinion, and it could challenge the credibility of the system. And of course, it needs coordination between all stakeholders, patients, medical care, medical institutions, and medical. So there is a path in the reform process that we need to understand and control. Even if we were to achieve universality by 2 years, and a system is ongoing, is witnessing ongoing changes and amendments, but this reform system should be really understood to anchor this very ambitious project in the whole project, the whole large-scale project, and the necessary reforms that need to be undertaken to accompany this project. So the relationship between the medical coverage and public health policy is absolutely paramount to determine the health ecosystem in its globality. How can the EU or European experience be useful to us? So the Honor Excellency, the Ambassador, has said it. We have a long-standing experience of twinning, of cooperation to consolidate our healthcare coverage. And we need to draw important lessons from this experience, enriching lessons from this very, very interesting experience, and to adapt it and better enhance it, knowing that in this prospect to extend and enlarge our medical protection, as Moroccans, we need to understand the various different experiences of Europe in the medical health services. We know that there are varied experiences with diverse experiences and typologies and systems, without going back to the historic fundamentals, but there is very much so a fundamental and common pillar and fundamental basis. So to me, to my humble opinion, the experience that we could draw from the European experience, of course, to be added to technical assistance project and endogenous project, is to maybe highlight and shed some light on how Europe has regulated the regulation of the diversity of the systems, the medicalized regulation in the relationship between public services and public players with the private sector, the financial regulation, the quantitative regulation of the offer, and the incentive regulation, in a way how Europe did involve all partners and players in this dynamic. So this mechanisms of regulation is, to me, very interesting indeed, and we can learn so much from it, because they include and encompass all the major questions that, for me, allow a system to be on a continuous reform process to adapt the changing needs of citizens and the system, whilst achieving its balance and sustainability and long-lasting sustainability. So this is, for me, one of the major chapters we should have a very rich dialogue on with our partners. So what lessons should be drawn from the regulation system in EU, in Europe? Thank you very much, Mr. Arabi.
Thank you for this presentation, and thank you for these very relevant issues that you raised that will help Madam Ambassador to continue to push this topic forward, because you, as I had announced beginning, this is not an event which is meant to conclude a topic, but rather to start a discussion. So I have received some questions because we have an audience that has been following us closely on social media and that have submitted a few questions. So I'll submit a few questions to the panelists, and then I'll give you the liberty of answering them. So what are the institutional challenges that the project's implementation has been faced with? How could we head towards universal coverage? I believe they've already answered this question, but maybe Mr. Adnan, maybe in a very brief nutshell, could you maybe tackle this question? I believe that this framework law on social protection does address quite a few questions that we've all been asking ourselves for a few years already. And I would say that it's the royal path to head towards universal social protection or universal medical coverage. The institutional challenges are achievable. And so there are a certain number of laws that need to be overhauled or even radically changed, or certain laws that are already in place need to be radically changed given the existence of a certain number of organizations, or the ANAM or the health authorities or ACAPS, ANAM, etc. So it seems that there's some sort of redundancy that we seem to note. But the main challenge, I'd say, is steering on governance, and I believe that time is of the essence here, and we need to move to action here. So what are the reforms for health policies to support the effective implementation of the generalization of medical coverage? Do we have a framework that would include the general form of hospitals as a health card, the regional organization of care, training of medical staff, and targeting tools? Mr. Anas, as a former minister, could you maybe tackle this question? So, in fact, it seems that it's a question that already includes quite a few answers and solutions. In my presentation, I mentioned a few. I would say that we are on a sort of fast track here. We have this desire to speed things up, whereas we've spent quite a number of years to adopt laws and to broaden a compulsory medical insurance scheme, to open up to vulnerable populations. It took quite a number of years. And it is important to stress, nonetheless, that political will is important, and it has affirmed itself well beyond the divides that may exist in society. And there's an economic situation that is challenging, and if maybe things would have taken a more progressive stance if it was more of there was more of an economic focus. So we need to ask ourselves the question if we have the means to achieve this generalized medical coverage system. But I'd say that we need to reverse the paradigm. We need to have this desire to achieve this. And I'm sure that these resources and means shall come. It's important to note today that the tax reform has not yet reached its limits, and it still has quite a lot of potential. The health care sector is not a social sector only. It is also an economic sector. There still is a lot to be generated in terms of tax income, which represents today 5 billion dirhams. Generalizing compulsory medical insurance will bring forth more government. So Mr. Adnan has a major issue, and this is something that he's constantly repeating, and it's based on a fact, and there's a trend here. If there is no disruption here, we will head towards a system, a health system that has two components, one public and one liberal. I prefer the term liberal than private, which includes foundations and clinics, private practices that do have a public mission per se, pharmacies. There's no public pharmacy. I mean, all drugs are purchased in private pharmacies. There are very few dentists with a public practice per se. So it's important to stray away from this competition between the public and private sector. We need to invent new modes, new modus operandi. Health for all is a priority, and as such, there needs to be a public institution that is the guarantor of this principle. And who will oversee this? Who is ready operationally? I mean, that's a whole other ballgame. It's true, Mr. Adnan is right. If tomorrow we were to give the beneficiaries of the RAMED scheme a medical form, I mean, will they actually go through the process? I mean, will they go through the process? Will they go to a public hospital, or will they go to private clinics? I mean, take a look at the private clinics. Take a look at the population that goes to these clinics. I mean, many of these people do not have medical coverage. They cannot afford medical care. So we are still, and this is in terms of medical expenditure, we are still on pocket ratio of more than 50% that is borne by patients. And for the drugs, where drugs represents the major portion of this expenditure. If we want to save public hospitals, because this is a major public expenditure, it's 16 billion dirhams in the pipeline today, with a university hospital in Tangier that will be completed, in Agadir, in Layun, and others that will be arriving, because obviously we'll have to generalize university hospitals in regions, and we cannot limit ourselves to a foreign medical doctors. We also need to have our sovereignty in terms of resources. We are indeed lagging behind, but nonetheless, hospitals in the provinces, local hospitals, all represent major investments. Who will they be left to? I mean, if we continue with the same modus operandi, if we continue with the same incentives for medical staff, if we continue with the same supervisory mechanisms, this is why I was saying earlier that the reform of the public administration is absolutely important. We can speed things up. And what we're doing today is giving a certain status to medical staff. But I imagine that in the future, this physician or this professor from the public sector who will head to the private sector, well, let's switch things up. And this was mentioned by Mr. Adnan. It's important to ensure the flexibility for the public sector. I mean, we did this with kidney failure, and this allowed thousands of patients to receive medical care and avoid perishing away. So we can do that for radiology. We can do that for a certain number of services. I received one day the Minister of Health from Albania, and he, in fact, was an IT engineer. He completed his term, and his political party succeeded in implementing a certain number of policies, namely the health sector. And he said that I am about to take on the digital technology agenda. And what did they do during their term? Said that the hospitals remain public, but all of the services and we limit those to gardening and janitors. So it means that when a doctor arrives to the OR, all of the equipment is provided by a private company. If there is insufficient staff, they would resort to private staff. The sterilization is handled by private companies. The management of appointments is handled by private companies, and we provide, as such, these public hospital staff and physicians have to fulfill a certain number of hours, have to log in a certain number of hours, etc. But so the idea isn't to radically transform the healthcare system, but we need to support these reforms and talking the regulatory, legislative, institutional reforms, and we can support this public system, and maybe in the future we can no longer have to talk about two health systems, but rather without having to distinguish between the public and liberal health systems. Thank you, Mr. Anna. So I still have three questions before we can adjourn this panel. So in the COVID-19 crisis, this has more than ever illustrated the necessity to have a resilient social protection system that is capable of overcoming exogenous shocks. For example, the beneficiaries of the RAMED were able to benefit from a financial transfer to overcome the financial stress triggered by the crisis. Could this system be available in the event of another crisis? Well, it is indeed a challenging question to tackle. I mean, I must say that between the Ministry of the Interior that manages these aspects, the ANAM, CNSS, and CNOPS, and even the National Police Department, well, there's a cooperation network for the exchange of data, for the exchange of the insured databases, and this in fact allows these redundancies, or to have any redundancies in the system. And the idea is to first of all have exchanges with CNSS, with whom we've signed an agreement for the exchange of data, with the police. And so today, to ensure that a person, for example, is not involved in a liberal professional activity, well, our reference is the police and the DGSN. And so with the Ministry of the Interior, there is a very close collaboration. And in fact, this vaccination campaign was also involved the CNOPS and CNSS, and we were able to provide a great number of data to the relevant authorities in order to target certain categories and, for example, to target certain age groups. And so this exchange and this coordination needs to be institutionalized and needs to be cast in stone. And here, in fact, we are advocating for a single unique identifier. And this is something that we've been calling for a certain number of years. It's true that it's extremely challenging. It's extremely complex. However, if I'm not sure whether the unique social register, as it's steered by the Ministry of the Interior, can be a first response. In the white paper that we've prepared on the digitalization of basic medical coverage, we proposed for the national identity card to be the identifier for our insured, as well as a health card, because we do have experiences, namely in Belgium and in Estonia, where everything is done using the national identity card. We've had exchanges, and this is something we discussed on Monday morning. We've had different discussions with the police, and they're extremely receptive and open for this national identity card also be used for a health card instead of investing new projects where we necessarily have sufficient resources. I know, for example, that the quartiers Vital in France cost several billion. So we have our Belgian counterparts have abandoned the specific card in 2014. And so since 2014 to date, it's the national identity card that serves as the health card or medical card in Belgium. And for example, Estonia, even if it's a smaller country, well, Estonian citizens also use their national identity card for all social services. They pay their taxes, they can access medical services, and etc. So this is definitely a very interesting idea. Madam Ambassador, a question that's addressed to you. How can the European Union contribute to facilitate the interaction between state and non-state actors and support the strengthening of the role of the civil society in Morocco in the realm of social protection? So overall, we have actions and systematic consultations with all of the different civil society players, associations, and NGOs in all fields, in all the fields in which we are involved. For example, when we prepare a project, we have consultations with all stakeholders. And very often we reserve a space in programs for participation because we consider them to be actors that are very close to the population. So their insight is extremely valuable. And we also have specialized programs that are based on calls for tenders or RFPs, that target to non-state actors and nonprofit organizations in different fields. For example, the field for social security, involving social security, involving youth, and many different programs. But I'd just like to say a few words. It's true that we have never had an opportunity to discuss these topics amongst ourselves, but I believe there seems to be a great convergence on quite a number of points that are key in this topic. And I think that the legal basis is definitely there. And so the political will and the political commitment is definitely there. There's no question about that. However, the governance is instrumental, and how it can be how can be rendered more efficient, more effective, and more responsive to the needs. So there's also the question of financing, which is absolutely key. And if we put this in the grand scheme of things, we obviously have budgets that are allocated in our major programs, and this also means that the state budget needs to express the political priorities, because that's the purpose of a budget, which can give some guidelines to see what are the priorities. And this is also an indication of the role that the healthcare sector plays, or social protection in general. And the other issue that was mentioned is digitalization, which is an extremely important factor. In addition to the topic, the health topic, we are having talks with the different institutions on digitalization in particular. We're already very much involved in the reform of the public sector, with a strong involvement in the digital aspects. And so this is definitely something that we can consider in our future commitments, so with regard to the social protection. And when I take a look at the first analyses of experts that are tackling this issue and seeing how we can, the different areas that we'll be tackling in the near future, well, this is exactly that. And it's governance, sharing of information. And here again, the unique social register was mentioned to find a mechanism to have a sound and universal database And the examples that you mentioned, well, it's true that Belgium has made some very rapid progress. And so for a population of 11 to 12 million inhabitants, and also in even bigger countries, they are also examining this possibility. And so also with regard to what you said on the experience of member states, as a European Union, we have a general foundation. Well, we obviously require or request a general social protection without specifying this, because obviously countries have different systems. And Estonia, in fact, is one of the countries that has made the greatest progress in technology and digitalization. And in fact, within the European Union, Estonia is considered as a model in terms of digitalization. And so the idea is that the idea is to be able to draw the greatest advantages and benefits, to leverage the most, to capitalize on these experiences. And so for Morocco, we can also leverage these experiences from Estonia, Belgium, and Finland and whatnot, and we can definitely learn from these systems. We have some systems that are also quite conventional, that are maybe not as interesting, because Morocco here has a very ambitious vision, so it's obviously preferable to focus on the experience of those countries that have made the most progress in this regard. And so the last question from the audience is, how can we improve and at the same time sustain the basket of care? I'm not sure if Mr. Larabi would like to take this question.
The question of the coverage basket has led already a long time ago when the AMO was being designed. And the question was, should we go for like a small basket and go gradually into the coverage package, or should we bet for a larger medical package in terms of medical coverage? Because not only you need a medical healthcare package, but the rate of packaging, and who is the moderator, the counterpart, and the fees paid by the contributors, etc. It seems to me that we have a quite inspiring experience, which is the AMO one. But we need to understand, in the framework of this liberalized regime, are we going to build on this experience and capitalize on it, or should we consider going into a less or fairly less ambitious package, a basket, which is quite delicate? And the question is to maybe go towards like a unique or differentiated basket. And these are two different type of regimes. How we going to be operating between two regimes? And if we go towards these two regimes, we need a uniform, harmonized, a fair, and unique type of package because of the solidarity. And this is actually the whole problem in terms of pricing and basic pricing, etc., with KNOPs, etc. This is a key question. It can only be answered in the framework of consultation and negotiation and involvement and implication of all actors. If we succeed to go and get this virtuous system, in other words, a system where there are no bias, no leaks, where all players and stakeholders commit themselves truly and totally on a series of standards and comply with them and respect them for the basket to be truly important and successful. And the basket itself is also related to the issue of prescription. So you can have a basket that could be very small, but giving and resulting to some range of medications that are not really necessary. So we need to build a basket that is not really leading to discrimination, but also compatible with the financial constraints that could be evolving. A basket where all the moderator ticket could be bearable and affordable by the beneficiaries and the insured, and a basket that could give way to negotiation in a sustainable way, but also taking into account the financial constraints to avoid this continuous deficit that might end waiting on the fees and contributions or the state budget, at least for the population that is being taken on board and covered by the state. So it is about constructing and building a modality of baskets and achieving the balance between the products. And in that case, the information system could be extremely useful for follow-up and monitoring. And I think things are totally linked. So we need to understand what kind of health services that we're going to be providing, but how we're going to be guaranteeing them, provided the efficiency of the system be built on a series of rules, standards that are complied with by all stakeholders. So lastly, Mr. Adnani, last word. Yes, on the monitoring and steering of these complex projects. And I think that the Commission on the New Development Model referred to it and its recommendations. And I personally believe that we need like a payment project management office that could involve even the private sector in order to really have those reforms successfully achieved and scale up and speed up the universal coverage of medical coverage in our country. Because sometimes we have very well designed laws, but the good laws are only good when they are truly and properly enforced, because the law on the medical coverage and system is very good, but the application and enforcement decrees are still there waiting, and the laws have been promulgated in 2011, but we're still waiting for their enforcement. So I think the good health policy really will bring about a good coverage, medical coverage scheme, because most difficulties come from the national health systems. And if you do not have a health system that is fairly performant, it will negatively impact the access to medical insurance and healthcare services. To close on a positive note that will hopefully make us smile, public hospitals are really sick, so we need to take care of them too. We need to take care of them. Thank you very much, dear speakers. Thank you very much indeed for this outstanding quality of your interventions that shed some clear light first on the audience that has been listening to us. And many tracks and many proposals have been made, and we have a lot of food for thought. And just to say that there is a royal commitment and eagerness and willingness, and decision makers are all willing, but the issue of implementation is key. The governance issue, the orchestration and synergy and harmonization of all the decisions made by stakeholders. This is a cup of tea for everyone, and digitalization seems to be a mechanism that could help a lot in the implementation and achievement of universality of the medical insurance. We very much aspire to achieve a fair medical package and medical basket. COVID or post-COVID should be a unique opportunity for us to really build a new momentum, gain a new momentum, and build a new society based on fair medical services. This is one of the pillars of human rights, of democracy, and peace and security, and sustainable peace and security. I really hope that this discussion and debate will continue with our experts to really advise decision makers and assist them in the implementation of this large project, because 2022 is there, around the corner, is up tomorrow. So the lot of issues to bring about all the players, but we need to also comply with the deadline that was announced by His Majesty the King. I wish you all a great continuation, and thank you all for your attendance. Thank you very much.